reminder real quick. I think on the Mobi app, that there's a handout that we can get access to. Is that right, Mark? Do you know? Or? I think on the Mobi app for this conference, I think they've downloaded his little handout that shows the little diagnostic criteria on it. So, okay. Do we want to go ahead and get started with the next one then, or we can break? Okay. So we'd like to at this time go on with our next lecture, and we are going to talk about public health measures to combat the rise of congenital syphilis. And our speaker will be Dr. Shelly Lawrence, and she's an associate professor of pediatrics in the Division of Neonatology at the University of Utah. Following her fellowship, she dedicated the first 6 years of her career to high acuity private practice neonatology to a neonatology group before transitioning back into academic medicine at the University of Utah in 2010. She received her Master of Science degree in clinical and translational medicine in 2013 and relocated to University of California at San Diego for several years. Her research interests focus on understanding the fundamental mechanisms of bacterial pathogenesis and neonatal innate immune system. She designs and conducts multi-center clinical studies with the primary goal of translating innovative diagnostics and therapeutics from the bench to the bedside. She has active NIH-funded research to validate for validation of new technology in the rapid and low-cost detection and identification of pathogens. She is also collaborating to investigate the use of host cell membrane-wrapped nanoparticles as a novel adjunctive therapeutic for neonatal sepsis. She has also contributed to several books in leading neonatal textbooks, including Remington and Klein's Infectious Disease of the Fetus and Newborn Infant, and Fetal and Neonatal and Physiology and Neonatology Questions and Controversies. So anyway, with that, would like to welcome her to the stage, and thank you so much for being here.
Thank you. So it's really an honor to be invited to come talk to you about another love of mine, which is congenital syphilis and the spread of syphilis over the last few years. My colleagues lovingly refer to me as the syphilis queen, but I would say that due to, obvious reasons, that's not my favorite title. I do work with a group of very talented people that I would just like to make notice of with the health department, with PEDS ID, with OB, and others. So instead, we have lovingly named our group CAS, or Crusaders Against Syphilis. So that's a name I don't mind being known for. I don't have any disclosures, but there's a lot of references that I'm going to use in my slides. A lot of them were also used in book chapters. But I thought we would go over some cases. My first case was actually in 2023, so I've only been at the University of Utah since 2021. And I came from California, where syphilis was already pretty much increasing, and we were seeing a lot of cases. When I first moved here, I reached out to Nikki Bear with the State Health Department and said, hey, I bet syphilis is on its way to Utah. Can I be of help? And she said, no, because we didn't really see any cases the year before. So I'll let you know we start seeing cases. And so August 23 was when we started to see our rise here in Utah. So the first case I'm going to discuss was a 27-week infant that was transferred to Primary Children's Hospital in Salt Lake City. And it was a well appearing. The mom's labs were reported as within normal limits. And I want to just put a little asterisk here. When we hear that labs are reported as normal, but we don't see them with our own eyes, it becomes a problem. And this case represents that really well. So an astute bedside nurse heard the family talking about how they thought the mom had recently been diagnosed with syphilis. So she alerted the attending, who called the referring hospital and said, hey, I don't have the actual printouts of the lab. Can you tell me what you were seeing in mom's chart? And so the nurse said, yes, the RPR was reactive, but doesn't that mean that she's immune, like rubella? And unfortunately, in this case, it meant that she was positive. And when the baby was tested, the RPR was elevated. And so this was a near miss. And then in September of that year, we actually did get a very ill-appearing 30-week infant at one of the Intermountain hospitals that was in liver failure in DIC with high drops. And here the mom had some housing insecurity and limited prenatal care. And her drop-in labs to that outside hospital showed her RPR was 1:64. Mom also said the nurse commented on her light generalized rash, like, wow, what a weird rash this is. But that's as far as it went. So the baby's RPR was also 1:64 in the nursery, but was not caught at that outside referral hospital. That our neonatologist called them and said, hey, this kid has congenital syphilis. You need to also treat the mom, but unfortunately the mom was discharged without recognition that she had secondary syphilis. So this was a mismaternal diagnosis, which I don't have to tell many in this room that once mom is discharged, she doesn't really have a primary doctor. Trying to get her treated for a STI is very difficult. So it took contacting many clinics to get her treated with penicillin. My last case is probably one of the more interesting things and things that we don't really know about syphilis, especially in pregnancy and the spread of congenital syphilis. This is an interesting mom because she presented in preterm labor with triplets. But here she had a history of syphilis in her past before this assisted pregnancy. And it was in the 1990s outside the United States, and she said she received all 3 doses of penicillin. But when she moved to the US in 2022, she became pregnant before she delivered these triplets. And because in the state of Utah and many states in the United States, if you don't have documented treatment for syphilis in the state that you are pregnant, then your treatment previously doesn't count. So she underwent repeat testing for latent syphilis, got 3 doses documented of penicillin, and her RPR remained serofast at 1 to 8. But at the time of the delivery of the triplets, her RPR was even lower at 1 to 2 to 1 to 4. But for whatever reason, the neonatologist was looking through the mother's chart and realized that they started treating the mom again. And when they called the OB didn't really understand, other than it just seemed like the right thing to do to give the mom more penicillin. There was no one thing that they could put their finger on. But the neonatologist worked the triplets up, and they all had bone findings of congenital syphilis, even though she should have no risk factors. So in this case, it was a near miss times 3, and PEDS ID was consulted, and we think that the mom just had latent syphilis, that she must have had neurosyphilis, or that syphilis was hiding out in immune privileged states in the body. But this is things we don't understand about syphilis and its spread during pregnancy. So William Osler was a really wise 19th century physician who helped found Johns Hopkins. And he said, to know syphilis is to know medicine. And I will tell you that we don't understand syphilis, and I understand that there's many fields of medicine that are continuing to grow. And syphilis is still really hard for many people to pick up and understand exactly what it is and how to treat it. But if we look at all the STIs, if we start with chlamydia and gonorrhea, we can see that gonorrhea has decreased 7.2% over the last year. Chlamydia rates were fairly stable. And so that's good news. When we look at syphilis, overall cases, and this is from the CDC 2023 data, overall syphilis cases are going down because we're catching primary and secondary cases of syphilis. But what we're missing is these late latent cases because they are tricky to try to diagnose, and they usually remain untreated. So when we look at congenital syphilis, the rise in the last year from 2022 to 2023, last year's we have data for, I can say it is slowing, which is good news. So over the last year, there was only a 3% rise in the rate of congenital syphilis. But if you look at 2021 to 2022, it was a 30% rise. So we are starting to figure it out. But what is syphilis? Historically, it's been referred to as the luz, which is Latin for plague. It's an STI caused by Treponema pallidum. In 2022, the World Health Organization estimated that 1.1 pregnant women were infected annually. And alarmingly, 2/3 of infected pregnant women will experience adverse pregnancy outcomes, including stillborn, abortion or poor neonatal outcomes. But Treponema pallidum itself is a gram-negative bacterium that is highly sensitive to oxygen and temperature, so it doesn't really live outside the body. So when you hear people say that they picked it up on a toilet seat, that doesn't quite fit what we know about this pathogen. It cannot be grown in standard cultures, and outside of humans, only rabbits and primates infected with T. pallidum will develop early disease, but they will not pass it on to their offspring. So it's really hard to study in a laboratory setting. And there are different stages of infection as well. And primary and secondary syphilis are the early forms of syphilis. And early latent syphilis, by the CDC standard, is syphilis infection that has been acquired less than a year. The World Health Organization says 2 years. But over this time, then you start to develop latent syphilis and tertiary syphilis. So when we talk about the primary stage of syphilis, this is when we develop the chancre. And the time between syphilis infection and the start of the first symptom can range anywhere from 10 to 90 days. That first lesion or chancre usually begins at the site of inoculation, and it is a dark red macule or a papule. But those lesions will progress rapidly to this well-circumscribed flat ulcer with a yellow crusted coat at the base and an indurated circumference. But these chancres are often unrecognized in women because they cause no symptoms and their location can be difficult for detection. So as a result, only about a third of infected women are diagnosed in the primary stages of infection. Those chancres can appear 1 to 3 weeks before the serologic response that we test for, aka the RPR or the EIA test. And so detection at this stage cannot be done by serologic methods. It has to be done by actually obtaining a sample of that ulcer. That chancre lasts for 3 to 8 weeks, and then it usually heals without any treatment. But secondary syphilis usually have a rash, and it occurs 2 to 10 weeks after the primary lesion. And this is caused by when the T. pallidum actually enters the bloodstream and becomes disseminated. And the symptoms might also be similar to what you would see with other viral-like illnesses or flu-like illnesses: fever, fatigue, weight loss, anorexia, pharyngitis, sore muscle aches and pains, arthralgia, or generalized lymphadenopathy. But this rash can look very differently in many different people, and it is contagious. So some characteristics is it often tends to present on the palms, the soles, and the trunk. It tends to follow the skin lines. Lesions, though, can be pustular, popular, nodule, ulcerative. They can itch, and they can cause granulomatous disease. They can be itchy, they can be faint, hard to recognize, and they can occur in the mucosa of up to a third or half of patients. It can also cause alopecia or hair loss, as you can see with the man that has the missing spots of hair. And the rash can appear as the chancre is healing. And T. pallidum can be isolated from the cerebral spinal fluid in about a third of adults with untreated secondary syphilis. And signs and symptoms of secondary syphilis will usually also resolve without treatment. But some of the cases that are untreated will progress to either latent stages or tertiary stages of infection. But keep in mind that primary and secondary syphilis are the most infectious and transmittable forms of the disease. And this is the stage 2 where a single dose of bicillin or penicillin G benzathine can cure this infection. There's also, though, out of Chicago last year, there was reports of some atypical presentations, even outside of patients that have risk factors like HIV or immune deficiency. And here it was called NOO disease, or neuro-optic ophthalmic syphilis. So here we had people presenting with vision or eye problems, headaches, dizziness, and personality changes or altered mental status. And in this Chicago region, most of these cases, 2/3 lacked the chancre or the rash. So you have to have a very high suspicion that if you don't know what you're dealing with, you have to consider syphilis in your differential diagnosis. Now, this is the most recent graph from the CDC, and it shows the rise of syphilis, primary and secondary syphilis, among reproductive age women, 15 to 44, over the last 10 years in the United States. And I'm going to put 2022 and 2023 together. You can see that in Utah, we've had more cases, where other states have had less. Our surrounding Colorado and California have had less. But compared to 2014, everyone is seeing a spike in in primary, secondary syphilis in reproductive age women. Many of this is because of the male infection rate is higher, even though women have caught up, and I'll show that on the next graph. So when we look at male to female ratio over the last, since 1990, you can see that that ratio continues to get less and less because more and more women are becoming infected. It is nice, though, over the last year that we're finally seeing declines in all men, women together. But alarmingly, many of these syphilis cases are in populations that have difficulties accessing medical help. So when we look at who is primarily the most infected, you can see that American Indians and Alaskan Natives have the highest infectivity rate, even though they represent a very low number of cases. We need to make sure we're paying attention to know that ethnicity matters. In this graph too, you can see that Black people have a very high rate of not just also of rate of infection, but also a number of cases where white Americans are also at high risk. But we need to be sensitive to know that some of our ethnic populations struggle more than others. In Utah, you can see that from 2023 to 2024, we've had more women with syphilis diagnoses and a higher percentage of those. Well, actually, I take that back. Even though there's 41, it represents about the same percentage in pregnant women. But what I'd like to report that because of state measures that we're all working together, you can see that we've actually had a drop off in the number of congenital syphilis cases, meaning that we are capturing these during pregnancy so they're able to be treated so the newborn is not infected. In 2023, our unofficial number of congenital syphilis cases in the state of Utah is 14, and it's unverified, so just keep that in mind. So the two caveats that I would have you walk away with this part of the talk is any ulcer, regardless of its location, that is painless, indurated, and indolent and fails to heal within 2 weeks, you have to rule out syphilis as a cause. And any generalized skin eruption, regardless of its morphology, should be viewed as secondary syphilis until ruled out. And then I have to mention infection control, particularly in my line of work where we go to deliveries and we deal with infants. I sometimes see nurses not wearing gloves on a newborn, but I would caution that universal precautions for all need to be observed, especially for those that wind up having syphilis. Because those babies and the moms like the amniotic fluid, the baby that's covered in amniotic fluid or blood, they're considered contagious for the first 24 hours until they get the penicillin treatment for more than 24 hours. So any hospital staff that's had close contact or exposure to mom's secondary rash or chancre or any of the fluids, they need to be followed at time 0 and then at 1 month and 3 to 6 months to make sure their serologies are still non-reactive, and if it's a substantial exposure, they need to be treated. So let's talk a little bit about latent syphilis. It's defined as the period when patients are seropositive, but they demonstrate no clinical signs or symptoms. In the first few years, it can be interrupted by reoccurrences of secondary syphilis. Those treponemes can be present in the blood intermittently, and therefore they may cross the placenta into the fetus. And 60% of untreated patients with latent syphilis continue to have asymptomatic disease. But then there are a few that develop tertiary syphilis, and it's usually 75% of untreated patients that have latent syphilis for more than 15 years. Most of them will present with cardiovascular complications, and 9% will develop syphilitic gumas, which are shown in the pictures. And they usually are progressive in the fact that the central area becomes necrotic, and so that's where you get those ulcers, and so they'll have central areas of necrosis. But neurosyphilis is always a concern, and it occurs in about 15% of those with tertiary syphilis. In persons co-infected with HIV, it can occur at any stage of disease. And neurosyphilis can be asymptomatic, but can also have various presentations, such as tabes dorsalis, where, and if you look at this dorsal root nerve, that white is scarring from the syphilis destroying the myelin. And so that's all inflammatory destruction of the myelin sheath. And so people can have clumsiness, loss of sensation, and it's irreversible. So just to summarize the stages of infection, once you're exposed to the Treponema pallidum bacterium, then you're going to develop a chancre at that source of an infection in most cases. If that is remained untreated, then you're going to progress to secondary syphilis, which is hematogenous spread. That's going to progress to latent syphilis, even though you can have some breakthroughs of secondary syphilis again. Many of those latent stages will remain asymptomatic, but some of those will also develop tertiary syphilis over time. And when I say that syphilis can hide out in immune-privileged spots, that includes the eyes, the brain, and the ears. So syphilis can also be associated with severe, profound, acute hearing loss, which is, again, irreversible because it destroys the middle ear bones. So how do we test and screen for syphilis? I do want to say that last year, in April 4th, 2024, ACOG did recommend 3-point testing during pregnancy, including the first prenatal visit at 28 weeks and then again at birth. I will also say that there was a recent paper by the U.S. Preventative Strategic STI Task Force that said that this is working, that they feel like there's been almost a 50% decrease in the number of congenital syphilis cases just by testing moms at 28 weeks and at delivery. So this is very important that we do this 3-point testing in all pregnant women. So I want to say how syphilis does line up against other STIs that we do test for that most people feel like is just standard of care, being that the 3-point testing for syphilis is new. But when we look at even hepatitis C virus, many people still don't test pregnant women for hepatitis C. But if we look here, the latest numbers from the CDC said that almost 20,000 women in the United States have hepatitis C virus, and it will affect about 165 infants. If we look at Treponema pallidum, about 10,000 women will have syphilis, and it's going to infect about 3,800 newborns. All these are treatable infections, by the way. If we look at what is most often tested for with HIV and hepatitis B virus, you can see that it's a lot less numbers, but for whatever reason, people are more likely to test for HIV and hepatitis B, and they're more reluctant to test for hepatitis C and syphilis, even though these are where the numbers are, and it's also very curable. So just one more thing about diagnosing a chancre. Again, like I said, the chancre can appear before you have the serologic changes that we can test for with RPR or the newer reverse sequence algorithm with the EIA. And so if it's a chancre, you have to test those using either ARUP's genital ulcer disease panel or direct fluorescent antibody testing. Both of those target the T pallidum receptor antibodies in order to result a positive result. Now, if we look at serologic methods for testing, the traditional is what we usually will start with in many cases, even though I'm going to make an argument for the reverse sequence algorithm testing. I'm so sorry. I feel like I'm about ready to eat this microphone. So hopefully this is better. Sorry about that. But the traditional testing starts with an RPR. And an RPR is a non-treponemal test, meaning that it tests for, we'll get this right, it tests for things that the Treponema pallidum organism does that causes inflammation in our body, and it releases cardiolipin from our cells in our body. So it's the cardiolipin that RPR actually tests for. And so it doesn't test for the organism itself, it tests for an inflammatory response to the organism. So this is what was discovered back in the early 1900s that we still use today. It's amazing to me how many things in medicine that relate to infectious disease were perfected almost 100 years ago, and we haven't been able to find anything that works better. But RPR is still a very good test. And so if you have a person that is RPR positive, then we will confirm that with a TPPA, a Treponema pallidum particle agglutination test, and I'm going to show you what that is. But I will say at this point, there is not one single test that we can use to diagnose Treponema pallidum. It's usually a combination of tests that we use to get the diagnosis. Now, the reverse sequence algorithm starts with an EIA, which is kind of a fancy way of saying almost a PCR-like device. We have a light, if you will, that will attach to the antigen of the treponema pallidum and light up to let people know. Are you going to fix this microphone? Thank you. Oh, I don't know. Is that what the problem is?
There you go.
Okay.
Just don't speak that close into it.
Okay, so he put a filter on it, which is great because I need a filter at all times. So anyway, the EIA basically lights up if it sees what a treponema antigen that it is programmed to pick up. So if an EIA is positive, it will revert back then almost to the traditional pathway because that will then be reflex back to an RPR. If it's negative, though, it'll go to a TPPA. So it still needs 2 forms of confirmation in order to say that that person has syphilis. Now, when we talk about indirect treponema antibody serologic test, I already told you it's an indirect method to test for the treponema pallidum. But the nice thing about using a about using the traditional pathway is that we can get a titer. So we can almost see the degree of inflammation that treponema is causing the individual, and then we can test to see if it's either worsening, if we're not treating, or if they're reinfected. But we can also see if we're treating effectively by seeing that 4-fold decrease in the titer. But this is complicated by a prosome phenomenon that can happen in a small percentage of patients, and I want to make sure you understand what that is. And it's has a high biologic false positivity rate, but its sister, the VDRL, is the only thing that we can test for neurosyphilis in the CSF. You will see that some centers are offering a PCR test for CSF. It is not FDA approved, and the sensitivity is really low. I will say even a VDRL test sensitivity is only about 60 to 65%, but it's still the best thing we have, and so you should always send the standard that is recommended, which is the VDRL. But just know that the Moderna COVID RNA vaccine, it did interact with the RPR test, and so there was a higher false positivity rate in pregnant women during the COVID years. So if we look here at the zone of equivalence, and this is how these tests work. So hopefully you have enough of the reagent to react with the treponema pallidum antigens, and it forms this nice kind of glop that will then fall to the bottom of the test tube, and it's called agglutination because you get particulate matter at the bottom of the test tube. But if you have the prosome phenomenon, which is here, you have so many antibodies to what you're trying to find that you didn't dilute it enough that they're all interfering with one another, so you don't get them interacting in this nice glob. They still stay separated. So the woman still has syphilis, but you're not going to pick it up because you're not going to get the agglutination to be positive. But likewise, you can have not enough of the antibodies that they don't saturate those beads enough, and so they still remain separated. So something like this could happen in early syphilis or in late syphilis. So that's why the RPR test can have some problems. So if we look at the treponeme-specific test, and you heard me say a lot about the EIA, that's the treponemal enzyme immunoassay. And that's what AROP and many of the state labs in Utah are using. And these tests, again, specifically for treponema antigens, not the cardiolipin that the RPR test does. So we will use these tests for screening. The other nice thing is they can be done in bulk, and so it's cheaper and easier for laboratories to run these tests. And then if these are positive, then they'll go back to confirmation. The fluorescent treponema antibody test, this is not really done much anymore. So really most of it is the treponema pallidum particle agglutination test that is used for confirmation. And Intermountain Health was supposed to be putting these in their core lab. I'm not sure if that has happened. I do know it is coming, but right now AROP was doing all of the TPPA test, and it is offered 7 days a week. So if you need it, if you expedite it, you can get it within 24 hours. Now, the pros of these treponema-specific tests is you don't get the prosome phenomenon, It actually increases sensitivity in the late stages, and I'll show you some numbers. And again, automated rapid point-of-care test. But you still need secondary confirmation. And this is the key. Once it's positive, it's always positive because it tests for treponema pallidum, IgM, and IgG. So once you've seen it in your body, you're always going to produce those antibodies. So you cannot diagnose it again using these tests if the person was to get reinfected. You'd have to go back to the RPR. So therefore, it should not be used in neonates. So non-treponemal test, these tests can be falsely negative in early syphilis, and I'm going to show you why. And also, again, your immune response falls off as you start to enter those latent stages of syphilis. You don't have as much cell inflammation, so it can be falsely negative in late stages of syphilis as well. But we do say two dilution changes or a full or fold change in your titer. So if you go from a 1 to 2 to a 1 to 8, those are considered significant when assessing disease. So if you get a higher dilution number, a 1 to 2 to a 1 to 8, it means you're worse. If you go from a 1 to 8 to a 1 to 2, it means you need less dilutions to pick up that treponema pallidum inflammatory response. So the lower numbers you go, then the more treatment you're going to have, the less of a response you're going to have. And then it should become inactive a year after successful treatment in the early stages of disease. So this is what I kind of want to put in the back of your head. This serologic response to treponema pallidum, this is your IgM, IgG response. So if you send an EIA, and this is what that's going to pick up. So it can pick it up around 2 weeks when you start creating your IgM antibody. And it's always going to be really nice for those later stages of infection where it's almost 100% sensitive. If we look, though, at cardiolipin, which is what the RPR is going to pick up, it takes about 4 weeks in order for that serologic response to occur. And then you can see that later syphilis cases, here towards the end, no treatment, that titer response starts to fall off. But there's also this group that can stay sero-fast. They're always going to have a little bit of titer. And I think this is the group that we don't quite really understand, even though we say we don't have to worry about them. I'm going to tell you in neonatology and in the maternal fetal medicine, we worry about them because we've seen syphilis happen in these kids. And so this is that chart that I promised. You can see that when you start to get to latent and tertiary stages of infection, the RPR, the sensitivity really drops off, but the EIA is almost 100% sensitive. So the current recommendations from the CDC, ACOG, and the AAP is that there's a combination of testing during pregnancy. So we still recommend that you do an RPR during pregnancy, but we also recommend that you do an EIA later in pregnancy. So at the U, what we're doing is an RPR in the first trimester of pregnancy or the first visit, but then we're doing EIAs at 28 weeks and at birth. That EIA, you should be able to get back within 24 hours, so it should not hold up discharge if you send it during the labor process. I will say, though, at Intermountain Health, they are almost reverting 100% to the reverse algorithm. So repeat testing during pregnancy, if it's diagnosed before or treated before 24 weeks, then you want to wait 8 weeks before you retest the serologic response to treatment. If it's after 24 weeks, then you want to test at delivery, but you want to use the same qualitative serologic test. So you don't want to do an RPR for one and a VDRL for another. And you want to make sure that if you do an RPR and you see the titer, you repeat the RPR because you want to know if you're adequately treating the mom and the baby. So just remember, chancres need to be examined by dark field microscopy. And if you do have a pregnancy that is complicated by syphilis at any stage, please, please, please send the placenta because it will add increased sensitivity. There are different stains that pathologists can use to pick up syphilis in the placenta. The placenta is also more boggy and has other changes that we could strengthen our diagnosis of congenital syphilis if we have other tools to help us. So in adults, the recommended treatment for primary and secondary syphilis is benzathine penicillin, a single dose. If it's late latent or unknown, then it's 1 dose every week times 3. If it's a pregnant woman, she can't go more than 9 days between doses, or you have to repeat the whole course over again. During the shortage of benzathine, then in non-pregnant women, it was recommended to give them doxycycline, but it's a long course. For primary, it's 14 days. For latent diseases, it's 28 days. Now, I hope I can stress to you, penicillin is the only drug that you can use in pregnant women because it's the only drug that we know crosses the placenta to treat the baby effectively. If mom has a penicillin allergy, she has to undergo desensitization because it's the only drug that counts in syphilis in pregnancy. Okay, so let's talk a little bit about congenital syphilis. These are the rates since 1941 of congenital syphilis. There was a definition change in 1991. That was where that bump came from. But I will say in the early 2000s, we were seeing such a low rate of congenital syphilis that this is when the states really started to drop off in testing. So when I was a resident in the late 1990s, no infant left the hospital without an RPR. And we didn't get married in many states without a blood test, which I was naive and thought it was HIV given the age, but it was actually a syphilis test. So in the early 2000s, this was found to be not cost effective, so it started to drop off in many places. It's no longer in many states required to get a marriage license. And of course, we weren't doing it in the babies anymore when they left the hospital. So I think that also led to the rise then of what we're seeing today. We kind of fell asleep at the wheel. If we look at risk factors for maternal syphilis, you can see that young maternal age, multiple sexual partners are problematic, but I will say the top 3 that you're going to hear is drug use, housing insecurity, and exchanging drugs for sex. Now, just like the moms, we can see that there is also ethnicity differences with congenital syphilis, that Native Americans and Alaskan natives are going to be the ones that have the highest rates of transmission. But you also have Pacific Islanders and blacks that have the highest rates in those different ethnicity groups. Now, fetal infection with Treponema pallidum, I will say that most you're not going to be able to tell with using ultrasound or doing routine maintenance for that pregnancy. However, if you have a miscarriage around 20 weeks, that needs to be ruled out. That syphilis is not a cause. Non-immune hydrops fetalis, we see that. Prematurity, fetal demise, low birth weight. We see a broad range, but there's not one thing you can really hang your hat on of how it presents in neonates. And again, most are asymptomatic. But if the infants remain untreated, then they will present with this stigmata later on. And once the stigmata occurs, it's irreversible. So this is the most recent data. You can see by this graph that, again, most are alive, born, no signs or symptoms. And you can see then that small group of the neonatal infant deaths and stillbirths, this was estimated to be 279 congenital syphilis-related deaths. 252 were stillbirths and 27 were infant deaths. And just some congenital syphilis facts. If we had interventions that improve syphilis screening and treatment in pregnancy, we can reduce perinatal death by 50% worldwide. We know that 80% of adverse pregnancy outcomes related to syphilis occurred in women who received antenatal care at least once. And I just want to let that sink in. So it's usually because they weren't tested, or they were tested and you didn't know how to get a hold of her to let her know about her positive response. But 80% had at least one prenatal visit. And the extent of damage to the fetus depends on when the gestational age they got it. So the earlier they're infected, the more symptoms they're going to have of disease. And this is something else that I kind of want to point out because it goes towards what we decided at the university and Primary Children's Hospital, our algorithm for screening babies to any mom that had syphilis during her pregnancy or before pregnancy. So I want you to see that here in 2023, and I'm sorry, I can't read these numbers this far away, but there was almost 3,800 babies that had syphilis. But if we look, the majority had timely test. And I want you to follow the timely test down to adequate treatment here. But I want to point out that there was 9%, over 300 kids that were timely test. They had adequate treatment, but they still had signs of congenital syphilis. And this is the population that we do not understand. We do know that if mom presents with secondary syphilis, there are some centers, and it is a CDC recommendation that she be considered to have 2 doses of bicillin and not just 1, 2 weeks apart, because there is a failure rate in secondary syphilis that the babies can still develop congenital syphilis. So I know some of my colleagues in other states are giving moms with secondary syphilis 2 doses of benzathine penicillin, and that is allowed by the CDC. But it's not unlike the 2022 data. We had 12% of babies, kind of the same number. So because we don't know why these kids are developing signs and symptoms of congenital syphilis, despite the fact that they should have been adequately treated, at the university and Primary Children's Hospital, we are screening all babies that are born with moms with a history, either before or during pregnancy, to make sure that they don't have any congenital signs of syphilis. And we recommend that they at least have an RPR repeated in the first year of life. Now, the babies develop congenital syphilis due to vertical transmission through the placenta. So by definition, they start with secondary stages of syphilis. And because of changes that happen with the placenta and blood flow, there's an increased risk for transmission later in gestation, even though there's more harm to the baby the earlier that it occurs. And just keep in mind that, again, the baby presents the way it does because the placenta strains the treponema pallidum strains the placenta of oxygen and makes it harder for blood to flow, and then it causes a lot of local inflammation. So that's why the babies can appear so sick and or result in a stillbirth. So similar to moms, we have charts that show the surge of congenital syphilis in the United States over the last 10 years. And I'm just going to let this play out. You can see that all states, again, are having problems with congenital syphilis. And Utah is no different. But we can see that in the upper graph here, at least we're starting to level out a little bit. The rise is not as high as it has been in the past. And luckily, even though there's still a high number of stillbirths and infant deaths, even this is starting to decrease somewhat. So if I put the two, 2014 and 2023 side by side, you can see that we had 3,882 cases in 2023. We had 462 10 years ago in 2014. That's a 740% rise, which is improved from a 10-fold increase between 2013 and 2022. So we are doing a little bit better. But over that time, we still had total syphilis cases in women that rose 500%, so we still have a lot of work to do. If we look at where Utah is in the nation, we can see that we're 37th. We were 47th a year ago, so we have moved up on the chart. And a lot of that is because we're surrounded by states that have very, very high syphilis rates, including Arizona, New Mexico, and Nevada. They're in the top 6 in the nation. I do want to point out South Dakota has had a problem with syphilis for the last couple of years, as well as Mississippi and Texas, so they're usually in the top 5. But the problem being surrounded by these states is like Arizona doesn't have a centralized health department. It's all by county. And it seems that states that have a centralized state health department seem to do better by getting all the counties to work together. Now, also luckily, last year, the West was the fastest rising area of congenital syphilis. We have decreased that due to decreased cases, not just in Utah, but Colorado and California have also had success in dropping syphilis cases. So the South is once again the highest rate of syphilis rise in the United States. Okay, but in infants, how do they present? Most commonly, the clinical signs are going to occur within the first 2 to 8 weeks of life. So if an infant isn't diagnosed at delivery, just know that it can be still diagnosed within the first 2 to 8 weeks of life in general. They're going to have primarily hepatomegaly, jaundice. They can have the rhinitis or the snuffles. They can present with a rash. The skeletal abnormalities are not confused with anything else. The radiologists tell me it's specific for congenital syphilis. So if they call that kind of moth-eaten appearance of the bone and say it's congenital syphilis, it's congenital syphilis. They said there's nothing else that mimics that finding on the x-rays. Skeletal abnormalities, that's what that finding is, but thrombocytopenia. I can't stress enough that before you stick a needle in a baby's back, you have to test the CBC, because these babies are really showing up. They have no other clinical signs or symptoms, but their platelet count is 50,000. And that's not an infant that I want to do an LP on. But these are some common findings. A baby that looks otherwise healthy but has a big belly because of the hepatomegaly. This is the macupapular rash on the feet. This is the snuffles. That's highly contagious, has a lot of treponema pallidum in it. Sometimes they can have this peely rash, but these moth-eaten appearances at the bottoms of the bones are really pathognomonic. That was one of the triplets in our group from that x-ray came from. But they can have other signs and symptoms, including myocarditis, pneumonitis. They can have ophthalmic changes, bleeding, especially from the GI tract, and they can have nephrotic syndrome if they have enough immune complexes. But when they die of high drops, sorry, I don't think I can go back. But usually when they die of high drops and severe liver failure. So just keep in mind that, again, if you have a kid that has high drops in a stillbirth, it needs to be tested for syphilis. Now, when we look at CNS infection in infants, approximately 50% of newborns will have a positive CSF VDRL. But we have to also marry that with what the blood counts of the CSF are as well, because VDRL, again, is not 100% specific for treponema pallidum. It's the best test we have, and under the best circumstances, it's about 60% sensitive. So please make sure you send a blood count as well, and it needs to be a clean sample, because if it's tinged with blood, it's hard to know if that is positive because of blood contaminating it or if it's purely based on the CSF. But they can have other manifestations of CNS disease as well. So we look at late congenital syphilis. This occurs after 2 years of life. If it's greater than 1 month with a reactive syphilis serologic screen, then again, they need to be examined thoroughly, but the maternal serologies need to be reviewed, because you can never, in any child, I guess, rule out sexual abuse, and so they need to be referred to a specialist. So late congenital syphilis can occur in 40% of untreated cases. And the stigmata here I'm going to show you, once it develops, it can't be reversed. And it can start with regades, which is this kind of puckering. It looks like it's almost a healing scratch around mucous membranes or the mouth or the anus. But again, it will heal up. It'll always look like those lines. You can't reverse this. You can have saddle nose, because syphilis eats away at your nasal bone, so it depresses that bone. You can have a perforated palate. You can have Olympian brow, saber shin, and even higamentous sign, those big whopping clavicles. If you see this, though, that's pretty pathognomonic, because there's not many things that'll give you that pinhole palate, perforated palate look. You can have gluten joints, which is swelling within the joints, Hutchinson's teeth, the mulberry molars, and you can have this interstitial keratitis. Now, the interstitial keratitis, unfortunately, can present early, and this is one finding, even if you treat early enough, that this can recur, and so this does need ophthalmic care. There's also the Hutchinson triad, which is sensorineural hearing loss in the ear, because syphilis can destroy those middle ear bones, and then you get the Hutchinson's teeth and the interstitial keratitis as well. If you have internationally adopted children, they can remain undiagnosed or inadequately treated, so any international adoptions need to be tested for syphilis, and it's recommended regardless of the history or report of an evaluation of treatment abroad. So in our neonates, I with Sonia Muir with Pediatric ID and Brett Nelson have modified. This was a really nice schematic that came out of Denver Health, and we modified it to what we want it to work for Utah's children. And so we've even created EPIC build-outs that if you have EPIC, you can contact us and we'll give you our EPIC build-out for alerts that you have a positive RPR, EIA, or the treatment algorithm, so you can pick what treatments you want to have done. And again, in our care, even if you're less likely or not likely to have syphilis, we will still do initial lab work and x-rays to make sure that you don't have syphilis, and we would like to follow at least one other RPR to make sure that we can rule you out. I will also say that the PEDS IT team wants to be involved in any kid where there's any question, and I myself am always available to help in the newborn period. So for treatment, it's a full 10-day course of parental aqueous crystalline penicillin G. Benzathine and crystalline penicillin G2 are not synonymous. They are not the same drug. You cannot give one dose of benzathine and then have them come back in 7 days and give them penicillin G. It works completely differently. So the treatment for congenital syphilis is intravenous crystalline penicillin G for 10 days. At 8 days, you go from PID dosing to TID dosing to complete the course. If you miss a dose, you have to restart over the entire course. So we do recommend that you put a PICC line in that patient and not an extend well. The penicillin is really noxious to peripheral IVs and extend wells, so you're more likely to infiltrate those lines, which is why we recommend a PICC line. Now, the CSF should be examined if you can get it. But if you have a kid that has thrombocytopenia and is at high risk, just know that knowing what your CSF does not change the overall treatment. If you have congenital neurosyphilis or you don't, it's still a 10-day treatment course. You're going to follow them the same exact way. You can follow their serologies later on down the line, and you can do that CSF later if your RPR does not revert to non-reactive at 6 months of age. But it does not change your recommended treatment. For late congenital syphilis, these are the kids that leave the newborn period and the NICU and the newborn. The CDC says that you want to use also aqueous crystalline penicillin G for 10 days, and there's your dosing. But they also leave this little asterisk that if you want to give them a dose of benzathine penicillin G as they're leaving the hospital, just to kind of make sure you adequately cleared it from the CNS, the eyes, and the ears, you can give them a dose of benzathine penicillin G on the way out to lengthen your antibiotic course. So just in my last little follow-up here, I just want to say that our newborn development team will see any baby with suspected syphilis, neurosyphilis, because there is a small study out of Canada that showed that at least 27% of those that were partially treated or not treated could have signs of neurodevelopmental impairments. So any referrals to our neurodevelopmental center will be seen for suspected syphilis. Infants with any suspicion for congenital syphilis should be reevaluated every 2 to 3 months until a non-reactive test is obtained. If a neonate was not tested because the diagnosis was considered less likely or not likely, again, we want to see those titers at 3 months and non-reactive by 6 months. Neonates with a negative RPR or VDRL whose mothers were seroreactive at delivery should be retested at 3 months. And my fellow Brett Nelson has found that our follow-up of these kids that have been treated is really low. We're missing 50% of RPR follow-ups, and it's really important that we do those tests. So again, what's recommended at the time of suspected diagnosis is a CSF examination if the platelet count's okay, a CBC, as well as liver function test. And then we recommend long bone films, hearing screen, and ophthalmic evaluations. And we've already talked about the CSF testing. Get it if you can, but it does not change your treatment management. Just know penicillin will cure the infection, but treatment in the late stages does not reverse the stigmata. Significant changes and damage to the fetus that occur during pregnancy, we still may not prevent abortion even if mom is treated if sufficient damage has been done. If treatment occurs within the first 3 months, though, we don't feel like the stigmata will either occur or it can be prevented. But the one thing that can't is interstitial keratitis. But just know, even those osseous lesions, those will improve even without treatment of congenital syphilis. And then this is that study that I was alluding to. I pushed the button too fast. 27% of treated or partially treated infants. For the Utah State Health Department, Nikki Bear is your STI HIV prevention specialist. There is a syphilis disease plan that's listed here. If you need help getting benzathine penicillin at your clinic, this is a QR code that the state health department will help get discounted priced benzathine penicillin to help. We're not in that shortage anymore that we were a year ago, so we seem to have adequate doses that if you're still having trouble, please contact us because we want to help. And so what else Utah DHS is doing besides increased medication and prenatal care, they have a team, which is listed here, that will do one-on-one education with your providers if necessary. And then once we find people at risk, we do extensive background checks to see how we missed that patient, what things we can do to help treat that. For instance, we had a kid that left university that lived in Nevada that they were picked up 6 weeks later that they had a positive EIA at birth, and it was missed by the providers. And so we closed that loophole by putting alerts in Epic that will automatically notify everybody that gets in that chart that EIA was positive. But what can you do? Prevention is key. Talk about STIs and risk factors with your patient. Send the test and detect it and treat not just your patient, but any sexual partners. And just remember, no person is too young, usually, to have risk factors. And so even your young teenage patients, all of them, you need to ask about their sexual history and screen and treat if appropriate. This is a 24-hour hotline to the DHS help desk. I would ask everybody to put it in your phone. It's also 888-EPI-UTAH. But if you have a mom that comes in and you don't know about her treatment, but she said she had syphilis and she got treatment, this number will help verify, because they have records for everybody in the state. If they don't have a record, it didn't happen in the state, that person needs to be treated. But they will help you with deciding whether or not she's been treated and what needs to happen next. Just know when reporting in the state of Utah, it is a 2-person reporting system by law. So the labs usually have a process where any positive syphilis screen will automatically upload to the state health department, but is also provider is that second person. So just know that it's the lab, but also the provider that needs to let the state know. Okay, so this is what I'm gonna leave you with. 8 times as many babies were born with congenital syphilis in 2023 than a decade ago. 9 in 10 cases of congenital syphilis could have been prevented with timely diagnosis and treatment. And 40% of women who had a baby with congenital syphilis did not get prenatal care. So test again, and treat. Thank you.
Thank you for the presentation. I think it's very timely. Can we use that same contact information for adults, not just neonatal care of syphilis?
Yeah, so that number is really just set up to know about moms,
Okay.
especially in the middle of the night when you have to try to decide about whether or not you're going to treat mom and baby, especially for those of us that work in a NICU and need to know. If it's an adult, just know that it can probably wait till the morning when you can contact your local county provider, and that's what they would request. I also wanted to dispel the myth. The state health departments do not have the resources to do STI treatment and testing. Even outside of syphilis, they only deal with pregnant women that are suspected of syphilis. They are not funded or staffed for gonorrhea, chlamydia, HIV, they've been decimated, especially after COVID. So just know the health departments are struggling and need all of our help.
One other question is just the test of the chancre itself. I don't know if you could pull that slide back up. What swab is it? Is it the pink fluid one that's used for herpes and I think a nasopharyngeal for flu? Yeah,
so yes, it can be that. It can just be a routine culture as well if it's sent fast enough to the lab. But just know that you can always contact your lab because it's hard to know if they're going to do the ARUP multiplex kit or if they're going to do the dark field microscopy.
Okay.
So I probably would just check with your lab before you send it.
Thank you.
I had a question about the map that you had up, and it looked like Idaho was an outlier. There were 0 congenital syphilis cases, and I wondered what happened.
Okay, so full disclosure, Wyoming and Idaho are states that usually don't have their numbers up to date for the CDC like other states do. They usually lag behind. So their reporting is usually delayed.
So I actually just got a memo from our lab saying that if we order an RPR, it will be replaced with a total syphilis. Have you heard that term before?
I haven't heard total syphilis before. What lab are you sending it to?
Well, this is our lab at Tanner Clinic, and I think we're bringing it in-house. I'm not sure what it is. I'll find out from our lab director.
Yeah, I would clarify because, and this is the problem in neonates in particular, is that you're going to have labs that are going to want to reflex any RPR to an EIA, and I wonder if that total test does include the EIA, the RP, but you have to have a positive EIA to get to an RPR that then you'll get to a TPPA.
Okay.
That does not work in neonates. And so if you have a neonate, you have to call the lab and say, I need an RPR on this neonate because that EIA is not going to help me out, because that only reflects the mom, because it's the antibodies pass through the placenta into the infant. And I see that mistake happening more and more as the hospitals are making their own decisions to move to the EIAs without thinking about the patients that might be affected downline.
Thank you. Glad I asked. I'll talk to our lab director.
Yeah, and just also know then if that's the case and you're following a woman who's been treated, an EIA is not going to help you either. They need to follow the titers of the RPR. Thanks. Okay, thank you.
We'd like to thank Dr. Lawrence for that excellent presentation on the rise of syphilis. We'd like to announce our next speaker, Dr. Jeanette Brown, who is going to talk a little bit about